Great. Thank you, Teresa. So nice to be with everyone here today. I'm really looking forward to our discussion and to hopefully meeting many of you on the break or through lunch. Really enjoyed the first part of the presentation, and I hope that some of the stuff that I will cover today will really help put Ohio in context to a lot of the national changes that are taking place, and also highlight a few other states and some of the changes that they're going through. While they're not exactly the same, there's a lot of similarities, and I do think that things that they're learning in other states will at some point make its way into Ohio, no different than a lot of the things that you guys are learning in this transition are going to make their way to other states as things that other folks will want to do as much as what other states maybe will not want to do, right? I think we're all in this learning game together, if you will, and the shifts that are taking place. So just a little bit about me and Qualifacts. Qualifacts is one of the leading electronic health record organizations in the nation. I believe we have almost 80 customers here in the state of Ohio, and so we were intimately involved with many of our customers, especially in the recent changes that came out and had to be implemented in July. So I won't spend too much time sort of talking about a lot of the technical components today. What I really wanted to do was really sort of give you a sense of what some of the national trends were and tie those back to some of the unique things that are taking place in Ohio towards the end of the presentation. I've been in healthcare for 24 years. About half of that career has been spent working on the provider side of healthcare. So I absolutely am intimately familiar with the day-to-day operational needs and challenges of a provider organization and agency serving consumers and serving populations of patients. I'm also intimately familiar the other half of my career working for healthcare information technology companies. Those ranged from companies that eventually became Cerner. It was a company called IDX, another organization called Multimodal, which is one of the leading speech recognition and artificial intelligence companies around codifying data sets for clinical quality measures. And more recently as the CIO of a company called Cogent Healthcare, which was the leading hospitalist management company in America, where we were actually at the forefront of a lot of the bundle payments initiatives and a lot of the notion of actually looking more towards, I call them social influencers of health, as opposed to such things as social determinants of health. Because I think our hope, right, is that these things don't actually determine the outcome, but they might influence it if we don't address them or look at them. So what are the agenda for today that I wanted to cover really was what are these things that are actually driving a lot of the changes that we feel? Two is what is value-based care and how should we think about it and its progression? And I always like to think about it as a continuum. It's not an end state, meaning everybody's moving from left to right. It's everybody's going to have parts of their services being delivered at different points along that continuum. And then really we're going to talk a little bit about new delivery models, consumerism, and community care, what Ohio is doing, and then how really as agencies and as providers, you guys can become more and more prepared for these changes, not only as you look at the next year and the things that are being mandated and that are coming down and that you're working through, but also as you think about your strategic plans and you think, okay, well, what's 3 years down the road look like? What's 4 years down the road? And how do I foundationally put things into place? And how do I prepare for what is likely to be those changes? So a lot of macro trends taking place, but I think this image really gives us sort of the best view of how everyone's feeling. There's so many new questions that are being asked today that weren't necessarily being asked just last year or the year before. How do you think about consumer engagement within your agencies, and how do you leverage technology to do that better? How do you look at your electronic health record and maximize your return from those investments to not only deliver better care, but also get paid for those services in a more timely fashion? What are some of the ways that technology is being very disruptive? Whether it's extending care and being an extension of care, or in some cases even potentially replacing care, which is not meant to say that as providers, you're suddenly not going to need to interact or engage with consumers. You're just going to interact and engage with them in very different ways. And also, the way that you may get paid for those things is going to be dramatically different as you look at the years ahead. Obviously, mergers and acquisitions and or what I would characterize here as an expanded view of what a partnership is, meaning not everybody can be good at all things. No different than an EHR company or a technology company can be all things to providers and agencies. You might need a care coordination platform. You might need patient engagement platforms. That's in addition to sort of this view of an electronic health record. No different as providers, you may have a complex set of services and programs, but you may need to partner with other provider organizations or other ancillary services that really aren't necessarily your core competency to help care for populations of consumers in very different ways than the way we've thought about it historically. And then really, how do we leverage data better? I think a lot of us are sort of grappling with this notion of it's one thing to sort of have data. It's another thing then to analyze data and create action from that data. And then really the third component of data is how do I infuse my understanding of data to get the better outcome that I'm looking for, and do I know what that better outcome looks like, or do I have targets to understand what I'm moving towards and where I'm at today? What are my baselines today? So what's driving some of these changes? This is one of my favorite slides because I think it puts everything into context in terms of like, why are we going through all of this change? And it really is because what we have is unsustainable. If you look at the United States, it is clearly an outlier relative to every other country around the world when it comes to the quality of care that we're delivering and the cost of that care. If you look to the right of this slide, I think it's another sort of really critical data point, which is if you look at the United States, the amount of resources and energy that we spend investing in social services versus what other developed countries spend, again, it's a huge outlier and a large disparity. And I think that has both a direct and oftentimes an indirect impact on our ability to serve the consumer population, specifically that the folks in this room do serve every day. Some more interesting stats. Disability-adjusted life years and loss per 1,000 of population, the clear disparity here is that behavioral health care impacts that more than any other set of diagnoses or sets of population. If you compare that also then with the amount of money that gets spent in terms of mental illness compared to other conditions, you might be surprised to know, and it doesn't come off very clear on this slide, but what I would share is that if you look at heart disease, it ends up about right here, and then trauma, and then cancer, and then pulmonary. And so contextually speaking, this is clearly an outlier. One of the comments that Teresa made, and I thought it was really great, by the way, a lot of the studies that I've seen suggest that for every $1 that you spend in behavioral health care, you end up saving $3 on the physical health care side. The data that Teresa showed actually showed that to be much more impactful in the state of Ohio. I believe her metric was almost 1 to 5. And so what we do matter, what we do in this room and how you guys serve consumers matters to the economic stability of a state and a country at the end of the day. And I know that's one consumer at a time. I know we often talk about population health, but at the end of the day, it's really one consumer at a time that derives, right, what the metric is across the population. So we're going to talk a little bit about value-based care, new competitive models, consumerism, and a lot of the shift of services into the community and why that's so important. So what is value-based care? I kind of spoke about it before as this continuum, and we clearly have evidence here in the state of Ohio of sort of where some of these things are fitting. Before, it was very pay for volume, right? If you delivered a service, you billed appropriately for that service, you got paid for that service. It moved then towards, well, now you have to deliver that service. Now it has to be delivered by a particular kind of provider, a credentialed provider, right? An MPI now, as we've we've been going through in Ohio. And, oh, by the way, you not only have to report out what some of those quality measures are, so pay for reporting, if you will, was sort of the first shift there, to what I understand is happening that Teresa talked about in Ohio, that essentially next year you'll be in a position where you'll have these quality holdbacks. These are now penalties as much as there might have been incentives for reporting before. They're penalties for not reporting, or they may be penalties for not being within a threshold in terms of the cost of your care or the quality of your care for the populations that you're serving. And so you can see sort of moving left to right, more dollars become at risk, whether it be in you being able to thrive as an organization or even survive. And then we're moving to a set of capabilities that needs to go beyond, from a technology perspective, having and fully leveraging a complete electronic health record system, but also beginning to look at data and analytics and reporting, being able to look at patient engagement and business intelligence, which is different than just reporting. And then lastly, as we think about serving populations, shared savings, shared risk, capitation models, that I know a lot of the MCOs have strategic plans that's where they're going. When you look at that, there's a whole set now of other technologies that should be in the strategic plan of providers. That is, how am I going to leverage care coordination? What are my entities for care coordination? If you don't know what's happening in Massachusetts, they're already very much moving and have populations of their consumers that are being managed by a group of providers that are all unique and different, working together to serve a population. And they've needed to invest as a group into care coordination technology. That's why things like health information exchanges become much more important. That's why things like clinical information reconciliation becomes more important. Transfer of care, which we talked a little bit about earlier, becomes much more important and significant. Not only for you as agencies and providers to continue to get paid, but also for us to demonstrate some of the quality components that, again, Teresa had mentioned earlier. So what might it look like if we sort of take maybe a look at the near-term or the long-term future when it comes to value-based care? And it's going to look more and more like it's no longer currently maybe 70% fee-for-service and 20% if you go left to right on this chart. It's not going to be 70, 25%, and 5%. It's going to be more like 40%, 30%, 20%, and 10% of your reimbursements are going to be tied to these models. And then maybe where it ends up is something more like 20%, 20%, 30%, and 30%. Again, none of us can sort of predict the future, and I know that every state is sort of different. I'll give you an example. One of the states that we're working with actually just moved to fee-for-service. And I see a lot of people in the head going, really? Yes, there's actually one state in the United States that just moved to fee-for-service. And so you can see there may be in a very different place than the state of Ohio. Ohio might be in a different place than the state of Massachusetts or California or other states. We're all learning from each other around the country on how to implement some of these things. I sort of, the analogy I'll use is that of, if anybody knows what comparative effectiveness is, it's sort of like this national experiment around comparative effectiveness. It's sort of this petri dish of we're all learning about what's going to work, what's not going to work, and we're all picking different measures. We're all picking different approaches. Some are very sort of provider-driven. Some are very sort of hands-off. They're going to let the consumers drive this and push a lot more to the free market. Some are pushing it from a different place and essentially having folks that are truly managing care as a set of navigators and clinicians working in a team-based model. Teresa also mentioned that, and I thought that was spot on in terms of where a lot of the other states are moving as well. One metric and stat, and I know there's some managed care organizations in the room I thought was interesting, is in the summer I read two different reports, both sort of pointed to the same data point, which was United Healthcare in particular had an 8% savings. Some of those were shared savings with providers, to be clear, not all of them were. And when they looked at all the same quality measures based upon the baseline that they had before, they essentially had the same or better quality over the populations that they served, and they saved 8%. So it is possible And I won't go into all sort of the unique programs. There is sort of a unique report that's out there that would encourage you to go get, that sort of highlights what some of those unique programs were and what results those programs gave to get to that sort of 8% savings. Again, same or better quality. And a lot of them did have to do with things like patient engagement and coordinated care and taking off some of the notion of what you can do with your consumer populations, leveraging technology that before you didn't get paid for, that today you can. I think a really interesting comment, again, that Teresa made, or in Ohio, they were very deliberate. And I'm sure of this. I'm not an expert in Ohio, but the things I've seen in other states and across the nation, they're very deliberate about why they said it doesn't have to be face-to-face. Because they recognize not all services, from an efficacy perspective or from an impact perspective, right, have to be delivered face-to-face to get the same or better outcome. That's why we've seen such a dramatic lift in terms of the use of telemedicine or telepsychiatry and what that means to the consumer populations that you guys serve. And so I think technology is an enabler to really get us through this shift and get us to a place that really is lower cost and better quality care. Let's talk for a second about some of the competitive landscape and some of the changes taking place. And this is as much seen as a competitive threat as I would encourage this room to see it as a competitive opportunity. If you can stand up telemedicine and telehealth, if you can begin to have identification of those services that you can call and, when appropriately documented, get paid for them in new ways, you can really begin to think about your delivery model, your care delivery model itself fundamentally changing. Another great example we talked about today was thinking about your assessments differently. The only thing that needs to change there is the way we reframe how we go through the process of that assessment. And I think that is a tremendous opportunity for everybody in this room to really think about how changing that component of your operations can have a dramatic impact on the fiscal viability of each agency, but also on the quality that all of you, I know, go to work every day improving and working to improve. And then we really should leverage some of these things, whether it be tablets or phones or data warehouses. I mean, there's so much more technology available today than there was 5 years ago to really help us make some of these care delivery shifts and really extend services beyond the way we've traditionally delivered services. In a couple slides, I'll show you an interesting trend line that shows the services being delivered on a traditional place of service from acute or inpatient all the way through to outpatient, and what is then forecasted from what's going to be delivered outside of those clear lines of place of service to now what becomes more of a virtual service, which seems far out, but I would argue it's here today. It's interesting, especially having spent a large degree of my career also on the medical, physical side, if you will, of healthcare. There's so much emphasis and focus on overutilization in those areas. I would argue in behavioral healthcare, there's such an underemphasis on the underutilization of services that are available. And that is not a poor reflection on providers. I think that's really a poor reflection on us as a country, really understanding the linkage between us as a group of individuals and professionals that can directly influence a lot of those medical conditions, if you will, through the changes and the skills and the assessments and the tools and the expertise that you guys bring to the table. And this was just another example of somebody from, it was 3M actually, who was just sort of talking about this component of what we need to do as we think about not only delivering better care, but doing it at a much cheaper cost point than what we've traditionally done. We all know, right, that sort of moving from inpatient to outpatient, we didn't see, we actually improved quality in most areas. And the cost obviously is much less. The same thing as we think about the shift to the home in many respects, or to the community. One of my fundamental beliefs is that the trunk of the tree is truly changing. meaning we've had a system in the past that was very focused on the service. And much of our conversation this morning was focused on what? The service, and how to categorize and define and deliver the service. A lot of the conversations then began to shift to, well, it's about the provider. Look at the state of Ohio. Well, what's credentialed and who's qualified and what scope of service and how do you document that? Someone once told me, you need to bet on the inevitable outcome. We can all have a nice debate and discussion about the when, but the if, I don't think, is a debate anymore, right? The consumer has to be the trunk of the tree. The provider, the place of service, the tools, all of these other components essentially will begin to hang off a different trunk of the tree that really is the consumer. And our systems need to be aligned and support that. And so obviously, as a technologist and somebody who thinks, how do I enable those changes, there's a lot of system changes. There's a lot of operational changes. There's a lot of changes that have to take place in every facet of healthcare to truly get to what I would consider to be the inevitable outcome. Because that's how people are going to get paid in the future. And it's not because the payment model, it's because that's actually where the costs are. They're at a person level. They're not at a service level or provider level. The costs truly are we helping consumers manage their diagnosis through creative and innovative treatments that leverage technology that is here and available today. 82% of healthcare consumers use online reviews. And I know there's been some debate in particular, and I've seen the studies that sort of highlight, well, it depends on the population. Not everybody has a cell phone, not everybody. I would argue that a lot of those, that's a lot of folklore. Not saying there aren't still pockets. I'm saying there's a lot of folklore with a lot of those statements and a lot of that data, because if you look at almost all the data that I've looked at, you would understand that access from what tool sets and what technology is available, I don't think that's the big challenge anymore. I think how to incorporate that in our view of traditionally delivering healthcare, that's the real opportunity. And consumers are hungry for it. They want it. And in fact, they're getting it either through us as agencies that are changing to new care delivery models, or they're getting it somewhere else. They're getting it through a Talkspace, for example. They're getting it through other service providers that do it in a very non-traditional way that don't necessarily have the same burdens that folks in this room wake up trying to solve every single day. And I would argue there's a tremendous opportunity for folks, especially with the resources and the expertise and the skills that exist in this room, to fully thrive in that environment by extending and augmenting the traditional kinds of services you guys are delivering. This is a chart I was referring to a minute ago. You can see it's fascinating to me that really in 2011 was the year that we crossed over in terms of expenditures. And you can see that this is sort of the outpatient line. This is sort of the inpatient line. And I would argue that we're not tracking community and virtual, but you're going to very much see this maroon line begin to look like this in the next 5 to 10 years. And it's going to happen much faster than this. That'd be my other comment. Like you're going to see it dramatically, this time dramatically compress when you look at the slope of these lines and what's going to happen in terms of services. And it's because the consumer population is changing at the same time that technology is changing, at the same time that payment reform is happening. And when you put all three of those things together, you get a compressed time frame. Movement to value-based care. This was from an Open Minds presentation. I think Monica did a really good job sort of with Kent Dunlap sort of providing this perspective, which again, this is not about when, it's really about if, right? And these things are glacial. They do move slow. They've been moving for 15 years, 20 years. We might only now be feeling some of that movement, but it's been happening, right? And I would argue that we will see a critical mass, and we will see that compression of time where it'll feel like it's even moving faster than glacial, even though it really is glacial. And it actually impacts every facet of business. It's not just the revenue cycle and the billing components that it's impacting. It's clinical delivery. It's how we engage with consumers. It's what we expect of them. It's what they expect of us, right, as a group of partners being technologists and providers working together. So those are some for the 4 trends. Let's talk for a second about Ohio and what's taking place in Ohio. And I certainly will not profess at all to be an expert in Ohio, although we do have a lot of clients. And I know we did spend some effort and energy making sure that we were supportive of the BH redesign efforts that came about this year. But would say that, the carve out obviously has been talked about. The 2310 loop segment for the NPI providers, I thought, again, it was a very good commentary this morning already about the credentialing. We didn't have credentialing, the burden that exists now, like a year ago. That burden is not insignificant. I know that in other areas of healthcare and other specialties, that is a huge part of the operation when they're onboarding and or partnering and or contracting with service providers, making sure that they can actually bill for their services. And that world got a lot more complex, right, in the state of Ohio over the last year. I think you guys are doing a marvelous job in the state. I think the resources that you have at your disposal and the thought leadership that has been up here this morning, you are a leading state, and you should feel good about that, as painful as I know this is for all of you. Incentive program payments to coordinate care. This is something, obviously, that is right here now, October, and then the expiration of dual eligible programs will happen in early 19. And then 50% of all Medicaid payments must be through a value-oriented strategy by 2020. Obviously, there's a lot more detail that you guys have here and that have been expressed this morning, and a lot more resources that sort of hopefully will help manage through a lot of this change. But Ohio is clearly taking action, as are most other states. So what can you do from a preparedness or a readiness perspective? I think, I'm a very practical guy, so, hopefully I gave you some perspective about why all these changes, what does it mean, what are the intersects from technology, and how do we think about sort of leveraging those assets to really, again, deliver care better at a lower cost. And then specifically, what are some of the things that as agencies, as you think about preparing for that, what are some of the things that you can do? And I think, I tried to put a list here together that maybe just gets you thinking about when you go back to your leadership teams within your agencies, what are we doing, right? What are we as provider organizations sort of doing in regards to any one of these points? And the first one would be just evaluate, measure, and collect and analyze against measures expected. Teresa, again, pointed out there's sort of 4 areas in particular that were in there relative to the quality incentive program. If you don't know what those are, would just encourage you to absolutely review those and then understand what needs to change within your organization, which is the second point. Review your current workflows against those requirements. Whether it's authorization rules, whether it's credentialing of providers, whether it's treatment caps or bundles, whether it's unique reporting requirements, whether it's measuring data that you weren't collecting before. I'll give you a good personal story here about an agency that I worked with that was really creative about what they were doing. They were having consumers discharged from the hospital and they went home, and what they found was that they had a high readmission rate and they didn't understand why. And it wasn't until they got social workers and LPNs and nurses to sort of begin to go out into the community and try to understand and assess what was happening in the community that might be causing some of this readmission, because it wasn't, were you complying with the medications, were you complying with, there was a lot of things that they were doing right, but they still had what they thought was a high readmission rate. And when they went out there, they began to realize, well, you know what? What's really important sometimes for these consumers who were decompensating was that they didn't have an environment that supported sort of what would be considered a comfortable temperature range. And you think, well, what do you mean by that? They didn't have air conditioning. Who collects whether somebody has air conditioning in their house today? By show of hands. That's phenomenal.
No. I went to an agency to consult with them, and they had no air conditioning. I almost got up and left. It was like during 95 temperatures, and I'm, having hot flashes.
Yeah. So I think I tell you that story. Because the kinds of data that we're used to collecting historically are not the kinds of data that we need to begin collecting now, and it's not for purposes of reimbursement always. Sometimes it's really to understand where the risks are so that then you can take on risk in serving consumers better. What I will tell you is that their program, they didn't know if it would work or not. They just had a hypothesis, right? They began to ask the question when people were being discharged if they had an air conditioning in their house. And when the answer came back no, one of the first things they did was they went out and bought 50 air conditionings, window units. And they began to put those in for a period of 30, 60, 90 days after, while the folks were recovering from this was surgery in this case. They didn't get paid for that, but they absolutely got paid for the reduction in readmission. And I used that as an example whereby I think one of the things that behavioral health does and is leagues ahead of anybody else is that you really take what in many respects is the collection through assessments of data or social influencers of health. You probably have the intuition that if you were to start to track the data would corroborate the intuition that most people in this room have about the populations they serve. But it's having that data and it's understanding why that data is important. It's measuring that data, and then it's having the hypothesis you don't need anybody else to tell you about that then creates the opportunity for you to get into what would be considered later on this list, having a meaningful conversation with managed care organizations or with payers about the kinds of things that you really can do if you're thinking about collecting data in different ways. Understanding the segmentation of consumer populations. Where do your consumers sit on a risk scale? There are many risk scales out there. I would argue if the payers, the managed care companies don't have a risk scale and that doesn't align with your risk scale, it's one of the first things you can work on together. Determine what a risk scale is. It's not perfect, but it aligns you to a place of where you would need to spend more resources versus less resources, or different kinds of resources in getting what you both want in terms of a collective outcome. Variation of care. I won't ask by show of hands because I've asked this question enough, and I'm always surprised by the results. If you were to take all of your consumers and put them on a grid, a distribution curve, would you know your bottom 10% and would you know your top 10%, regardless of what measure you're looking at? The other thing is if you were to look at all of your caregivers, all of your clinicians, and you were to put them on a distribution curve, would you know where they sit? And my point is there's two things that have to happen in terms of cost shift and curve, right? One is you have to understand where you're at today, where's the baseline and where your outliers are. If you don't know that, then you're going to end up spending a lot of energy and a lot of resources focusing on the thing that isn't going to move the needle. So if you know that this is your top 10% and clinical variability, and some of it could be warranted. I don't stand here before you and think that variability is not warranted. There's absolutely appropriate times when variability is warranted, as long as it's documented. Then we can learn from it and understand why it's variable and what we can do to make it part of what we consider to be the normal distribution. So understanding that, I think, is really fundamental. And one of the comments earlier was, if you haven't really thought of revenue cycle management as something that was really core to your business before, I would argue that all of you know that that's now core to your business now, whether you're doing parts of it yourself or whether you're using some partnerships like have been expressed in the room to help you with those areas. I would argue that that's insufficient. It's sort of not enough. You have to be thinking about this from a patient engagement strategy and from a care coordination strategy. And if you don't have strategies around those technologies or those tools, then I would encourage you at a minimum to start to think about that and identify what some of those capabilities are, because they're going to be required. You're going to be required to have access to them, and you're going to need to share them with a broader set of provider agencies who are together caring for that consumer. Understand your unit cost. I went through the painful exercise once of moving from an attribution-based model of costing to an activity-based costing accounting model. Who here in this room has gone through that experience? Nobody. It was probably one of the most enlightening things and painful things I've ever had to go through, because it really created a sense of awareness about the activities that we do every day and which ones were delivering value and which ones were not. And we stopped doing a lot of activities we thought were valuable and started to do a lot more activities that we always wanted to do, but that we never really fully understood the value of. I'm not suggesting everybody has to get fully to activity-based costing to have an understanding of that. What I am suggesting is that really understanding the drivers. It's one thing to look at a P&L or a financial statement, or understanding your cash flow, or all the other sort of financial tools at our disposal, right? As healthcare businesses. It's another thing to understand how it actually got on that line, and where your biggest expenses are, and how you're creating the right oversight over those expenses. And it's more than just a productivity report. I'll just state that. That's important. You need that. But productivity itself is sort of just one dimension. And if you only present data in one dimension, you end up not fully understanding the three metrics that together get you the business outcome that you're looking for. And so becoming much more sophisticated about that, I think, is something all of us are going to have to do in healthcare overall, but in particular in behavioral healthcare. And there's lots of, the good news is you're not alone, and there are lots of resources in these areas to help you as agencies sort of move further down that data-driven decision model. The last two I'll talk about here is just providing, again, if you've not really thought about who your partners are, whether that's transportation, whether that's billing services, whether that's primary care if you're not doing that yourself but you're partnering with someone else, whatever that looks like for you, would just encourage you from a preparedness and a readiness perspective, have a strategy, be intentional about it. Don't let it happen to you, but think, where do I want to be? And how do I work with these players so that they have the same outcome that I want? Does your EHR company, does your billing services provider, does your primary care partner all have the same vision? Are you all working together to achieve that vision that you're setting out for each other? I think is an important consideration. And then was already talked about here today, really continue to work and develop positive relationships with those payers. Another tool, Open Minds has some phenomenal tools for really going through as an organization. It's an assessment tool. It's available for you, and it really helps you plot yourself as an agency strategically along these different dimensions: provider network management, clinical management, customer access, service engagement, financial management, technology, which we've been talking a lot about, and then just leadership and governance. So if you haven't used these tools, would encourage you, especially as you move through sort of this notion of strategic planning that I assume all of you do, use these tools, because they really will point you to where you need to have either talent management plans or process redesign efforts in support of where you want to go. None of us have a crystal ball. This is hard stuff. Two areas that I think we have a unique opportunity within behavioral healthcare to focus on as we think about the next really 1 to 3 years. One of them is our understanding of the data assets we already have and an identification of the governance of that data for purposes of driving better performance in all areas of clinical attributes and also business attributes. The other one is, what is our holistic approach to our consumers and to our clients? Which again, I would say behavioral healthcare is better positioned than any other segment of healthcare for doing that. Because you're already doing a lot of that today. You may not know the value of doing that, though. And I think, again, when I say Teresa, I'm commenting, I think both of them sort of had comments in these areas. I think there's really a rich opportunity for you as you negotiate and as you sit down and partner with payers when you think about that kind of data collection. I won't go through this. I think I've commented on all these except maybe the last bullet here, federal and state reporting programs. You know, in some states, and I'm sorry I don't specifically know in Ohio, state reporting requirements are getting more and more complex, more and more difficult because not everything, for example, will be asked to be put in as a modifier, as we talked about earlier. But what I have seen, and I won't comment on the where, what, or on the appropriateness of this, I shared this with Teresa this morning, but I do know in one case where on claim data in one of the segments, they're asking for the PHQ-9 score because they want that quality data. Whether or not that's an appropriate ask and what that is a different question, but I think it points to more and more of where states and payers and others are trying to get out of not only the EHR, but also some of the other platforms that we've talked about today, sort of some of that data that helps them underscore where they should be putting more money versus less money because they're either getting a good return for that or they're not. And I think federal and state reporting requirements and programs are going to continue to become more and more important. And that's going to be more and more of a pain point, I think, for providers and agencies as they look to report out on what those requirements are. We all know, sort of commented on earlier, I think it was really sort of appropriate, we all reserve the right to get smarter, which means it's okay to do an assessment and think, well, this is just an initial assessment. I know something more than I did before the individual walked in. This is what I think today. After more progressive assessments and interventions that you're doing, I know more, and therefore this is the diagnosis. Or I think that's very true in all of these reporting requirements. I think as they're getting put out there, and we think, oh, it's so frustrating. 6 months ago it was this, and now it's this, and now I think you're going to see that accelerate. And so I would think about how you as an agency think about being prepared for that. And then the last comment I'll make is just, again, what data are you collecting and why are you collecting it? And how can you demonstrate for payers using technology that exists today all of these various facets of what I would consider to be social influencers of health, not determinants of health. And if you have an intuition, if your clinicians and your clinical teams have an intuition about some of these things and a hypothesis, this is science. Well, let's test it. I mean, that's the beautiful thing about what we do every day is that we're breaking new grounds. But we're not if we're not collecting the data and demonstrating that it actually has some efficacy, right? So cultural identity, social media, technology, accessibility, living arrangements. You know, we talked about air conditioning, sexual identity, transportation. All of these components become much, much more significant, I think, than any of us realize, and only now is becoming more of the forefront across other areas of healthcare, but that I think have been key components of this area of healthcare for a long time, and you guys are way ahead of that. Now it's just how do you leverage it? If you don't have a strategic plan around all of these facets, technology, revenue cycle management, new care delivery models, my ask of you is to consider that with your leadership teams and to go through that. There are a lot of resources out there at your disposal to help you get started. You may at some point in that process find that you've got needs. There are lots of partners in this industry that will be more than happy to work with you to move the ball further down the field, if you will. But I think you really have to be thinking about things holistically. What are you doing in terms of the shift of services to the communities, and how are you enabling that? What is your relative strategy when it comes to engaging consumers? How are you going to count services differently? In one state that we're working with, they have this notion of something called activity qualifiers, which is the definition of the service is changing. Now the service is a bundle of these three things. When these three things are done, these are activities. I'll call them services because they're not billable. They're activities. Now when all those three things are done, now we can bill. And here's a code for that. And so activity qualifiers will be something that I think will probably end up making its way at some point as we look about what's happening in different states. So how are you thinking about the flexibility needed to count differently for purposes of getting reimbursed? And that's true on the fiscal side. It's obviously most true also on the clinical side. I think demonstrating quality improvement, not talking about it, but actually demonstrating it. And then leveraging technology to really retain staff. I know this is a really difficult topic for a lot of providers who are struggling to sort of retain knowledgeable key staff. And I think thinking about your training programs and your technologies as a way to differentiate to help in retaining clients or employees, I think is a critical component that all of us should be thinking about. How to leverage data better, how to reduce clinical variations, and then I think something that doesn't get talked about a lot is sort of sharing the data. It's one thing to have the data, it's another thing to share the data. So at Qualifacts, we've done over 50 integrations between medication cabinets, Pyxis, to HIEs nationally, to labs. All of that is meant to increase efficiency and effectiveness for your care teams so that they can really focus not on the data entry components or the data integrity, but can actually deliver more meaningful business value by way of giving you time to care for the consumers that you go to work for every day. I hope this has been helpful. It's a little different, I think, than the context this morning. It was very technical around some of the billing components. I hope I've given maybe a little bit of a different lens by way of how to think about technology, how to think about your partnerships, how to think about value-based care. I hope you all understand the drivers for why those changes are taking place. And I also hope you leave optimistic, knowing that Ohio's in a good place. You really are thinking about things the right way. I think you've got some phenomenal resources here. And I'm excited to partner with you guys and help you get there. So thank you for the time today.